Hello, everyone. My name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC monthly webinar series. Today's session is on utilizing innovations in telehealth to advance the care of patients in congregate settings. Today's webinar is being hosted by the Mid-Atlantic Telehealth Resource Center, and these webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few housekeeping tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function at the bottom of your screen to ask questions. Questions will be answered at the end of the presentation. Please note that closed captioning is also available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. And with that, I will pass it over to Kathy Wibberly, Director for the Mid-Atlantic Telehealth Resource Center.
Hey all, good morning or good afternoon or wherever you are. So we are very excited to be presenting this webinar. It comes from a history of the pandemic, and 2 of our presenters are both former retired University of Virginia telemedicine office key staff, and they are now consulting for Matrix as well as on their own. And I'm just really thrilled to have both David and Mike with you, and they will actually do a little bit of an introduction of their background. So I'm going to save you from that and just punt directly to them.
Thank you. All right. And Kathy, greetings to everybody across the time zone. On behalf of Mike and myself, we really appreciate this opportunity to share our COVID story of reaching out to provide care in congregate settings. I have to say, as a disclaimer right out of the gate, that this was very therapeutic for us to do. It's important to tell this story. It is as much about the technical and policy aspects of telemedicine. It's as much about just the experiential aspect of what we did during COVID, and to tell our story with the hope that within these stories that you'll have some ideas about things to do to prepare for patients in congregate settings. I am very concerned, and I promise that while I tend to be hyperbolic, this is not hyperbolic. We are not still prepared for how we care for patients in these settings through telehealth. And hopefully our story today can help guide some advances, both from technology providers as well as clinical programs, as well as bigger telehealth programs. Yes. Slide.
Yeah, next slide.
So this is who we are. This is Mike and Dave's most chaotic adventure. And I'm David Gordon. I was the Director of Operations for many years at the Karen S. Ruban Center for Telehealth at UVA, as Kathy mentioned, and decided to retire right in the middle of COVID, saying, "I told you so" on the way out. But I still am a part of efforts to provide telehealth. And so throughout COVID, was working and developing services for congregate settings. Mike?
Yeah, and hi. Thank you all for having us today. I'm Mike Patterson with Toacher Technologies. Been around healthcare technology for many years, starting with radiology engineering. And in 1999, started working with the Karen S. Ruban Center for Telehealth at the University of Virginia. So several decades of telehealth experience. And ironically, as many systems as we've implemented and trained on, I'd never been on the receiving end of a telemedicine encounter until this past Christmas, when also ironically, I tested positive for COVID. It was a textbook encounter. I'm saying that so to set the stage for what you're going to hear. I logged into my chart, sent a quick message to my provider. Within an hour, a nurse called me, interviewed me, set me up an appointment a couple hours later with my provider. Provider was on time, video and audio was beautiful, 10 to 15 minute consult. 2 hours later, or maybe even less, I had my meds. She called them into the pharmacy. My wife picked them up. And so all I had to do was suffer through COVID. And, but this was a beautiful encounter. Next slide, please. So Toe-Tier Technologies partners, these are some of the skill sets we brought to the crisis. And you can see it's in the three big bubbles, it's a wide variety of from everything from engineering to training to building federal relationships, security, grant development, data analysis, and vulnerable populations. You know, our partners represent over 75 years of combined telehealth program or development. We had also worked together, so we knew each other real well. And primarily, we developed this for prison settings. And these are skills that we thought we needed. We're also in partnership with the University of Virginia Center for Telehealth and the UVA Health System. There's one bubble missing that that we learned later and we'll mention later, and that's the bubble of the nurse innovator. Next slide, please. So our aim for today is just to share our COVID telehealth experience and in congregate care facilities, to detail problems we had in reaching the most vulnerable populations, and tell you a little bit about what worked, what didn't work, and some lessons we learned, and then charge to us in the telehealth community to, how do we advance congregate care telehealth moving forward. But, we all have our COVID stories, so this is ours. Next slide, please.
Yeah, on March 10th, our story goes that we felt pretty good about the work that we had done over decades to establish relationship with congregate settings. We had done nursing home telehealth. We had been doing substantial work in prisons over the years. In fact, the prisons were really in large part where we began to provide telehealth. But when the flag went up on the public health emergency on March 11th, and we were watching the march of COVID across the country, we were starting to feel under some very intense pressure to make sure that we had available in the most vulnerable of settings with the most vulnerable of people capabilities. There was palpable community fears, and we weren't sure we were ready. We didn't have a clear plan to turn to. That when we had begun, our leaders told us long ago in telehealth that, hey, in 5 years' time, telehealth is going to be on every doc's desktop. Well, we weren't there, nor were our partner facilities there. We had fixed endpoints out and about in the world, but we had a lot of untested and uneven capability, uncertain broadband alignment. We had been operating under public health policies, the insanity of the Medicare rules that said, hey, you can serve a rural nursing home, but if it's an urban nursing home, and hey, Charlottesville's got a Starbucks, you must be urban. then we can't, we can't provide services under Medicare. And so that led us to being woefully unprepared for how we, in an environment where the disease was spreading and an uncertainty as to how it was spreading, to move forward. Not to mention there was such worry over personal protective gear, ventilators, the lack of iPads, the uncertainty about which telehealth technology. You guys all know this. You experienced it. We all experienced it together as an existential crisis. And that's where we began. We thought we were more prepared. We had said frequently, just wait till there's an airborne epidemic. This is really going to show itself. But here we were seeing the stories out of New York in March and out of Italy. As this New York City ED physician said, we're trying to keep our heads above water without drowning. We are scared. We're trying to fight for everyone else's life, but we also are fighting for our lives as well. That's where we started. Next slide. So the places we start are very important to note. When you read this definition that we've got on there of congregate care setting, it is a pretty broad definition, right? A congregate care setting is an environment where a number of people reside, meet, or gather in close proximity for either a limited or extended period of time. That's the CDC's definition. Well, that's everywhere. But with schools, with programs, with work, which are congregate settings, people could go home. But when we looked at our most vulnerable patients, those with significant comorbidities, those who were frail elderly, they were living in long-term care facilities, assisted living. They were in regional jails, statewide correctional facilities, problems we had right out of the gate with people in homeless shelters. There was a whole untouched area that we really had not thought enough about prior to this moment in March. And that was the developmentally disabled, people in group homes. So we started in thinking through how we were going to move into these settings. Next slide, please. And of course, who we found in these settings, were captured, we hope, in part by this image that you see here. There's that sense of people who were being isolated into a facility, who were frail and scared, alone, looking out the window at their family members, uncertain, unclear about what was happening, people with mental status issues, both rural and urban, not to mention all the people that surrounded them who were taking care of them. And again, this is all of what we all remember from the news and from the images we saw. And it was particular to the charge that we received at the beginning of the epidemic. How do we reach these patients? Which we quickly started calling our VIPs, vulnerable, isolated populations of people. Next slide.
So I was keeping up the news as well, and I'm like, this is getting real in our community. So on March 25th of 2020, that night I sent an email to Dr. Karen Ruban, the medical director of the University of Virginia Center for Telehealth, and just said, hey, if there's any way I can help, if you be of service, just let me know. I'm around. I also sent one to my colleague, David, here as well. That was the night of March 25th. March 26th, midday, I was fully engaged with the University of Virginia Health System and this crisis, and was getting equipment. We had kind of a unique charge, at least I thought so at the time. We couldn't go in sites, to include the University of Virginia. we needed to acquire the equipment from the University of Virginia, test the equipment, assemble the equipment, deliver the equipment, set it up, and train. And the training all had to be done remotely as well. So it was like picking up that pizza, driving it across town as fast as you can, and getting it to the home when it's still hot. So hence, that's why we coined the phrase GrubHub Telehealth. You'll notice in the pictures, I hope it gives you an idea of what we were doing. You'll see the nice Pelican cases up in the upper left. The kits, the first few sites we went to were in bags and cardboard boxes because we had to get it out quickly. You might also notice in one of these slides, you can go to the next slide, please, that the surroundings may look familiar. It was, this is where we are today. This was in my home. It was in my den, my foyer, my living room, my dining room. We were building it here, testing, making sure it works in a very controlled environment. I have a good broadband connection. So once it was up and running, we'd get a call to go to a nursing home. And actually, you can see in the what we were putting in the kits were iPads, pulse oximeters, blood pressure cuffs, thermometers, packing materials with consent forms, and and all of the other forms that were needed by the University of Virginia's Office of Telemedicine. We also had a great team in place of techs, technical people, physicians, program manager, and nurse innovator. We also were using as a sandbox as we're trying to build these kits and put them together and make them work and test them. We're also looking at, what else is out there. So once the system was ready to go out the front door, we'd get a call, we'd pick up the kit, take it to the site. We were in full PPE, we're sanitizing at every step. We would place the kit, may go to the front door of a location. I'd contact the person in there that we were meeting. They would come out, put the kit down, back up maybe 10 feet or so, and talk to them through PPE, then go back and sanitize hands and things, and then head back and do it all over again. Like I said, once again, GrubHub Telehealth. Since we're telling stories today, now realize March 25th, I sent an email. April 13th, there are a number of stories before then and after then, but on April 13th, it was about 2:30 in the afternoon. I get a call. I've been watching the email trail, but I got a call that we had a rural skilled nursing facility that had an outbreak. 41 out of the 48 patients had tested positive for COVID. 7 staff members, to include the medical director, I believe. So I got a call. Is there any way we can get one there quickly? We did. It took us about 45 minutes. Around 3:15, 3:30 in the afternoon, we dropped it off. But once again, I pull up in the parking lot, and there are a handful of cars in the parking lot, but I don't know if it's just because I was going through the crisis or not, but it was a very eerie feeling. So I contact the person I was talking to, the executive director, I think. She came out, and several other people in their PPE, which looks like hazmat gear, at the time, and drop off the equipment, they pick it up. We set a time to test. We go back to our office. We start testing that night. I think it was around 8 or 9 o'clock. It worked well. I'm meeting with a nurse our nurse manager that had been brought in from another facility, because realized they had people out sick at the particular facility. And there were patients on gurneys in the hallways, and so she's trying to take care of patients as she's working with me, get it done. It worked fine. Everything came up well. Got on the network, didn't take very long. I communicated that back to the University of Virginia. And then the next morning early, I think it was around 06:30, 07:30, maybe a little later, but the UVA team was rounding with that site. So that
virtually rounding
with that site, yes. And so I felt very good about that. And then moving forward a little bit, we couldn't go in any of the prisons. So we had an outbreak in another rural prison about 45 minutes to maybe an hour from here. And the prisons, like we'd said before, they had fixed endpoints. So the telemedicine and part of medical in the prisons back to the telemedicine unit at, you know, the University of Virginia or Virginia Commonwealth University or any others, that would work well. But all of a sudden, we're not being able to bring patients over to medical because they had to quarantine areas of the prison. So they had yellow, red, and green zones. So we're testing, you know, with cellular iPads because there's no Wi-Fi beyond administration in most of the prisons. So where the, you know, the wardens and, you know, the officers meet. So we had an outbreak, we tested there. Fortunately, the cell signals worked inside the area where the COVID positive patients were. And so they were able to work back to UVA and see some patients. And then, like you'll see, and then actually in the lower right corner, that's a picture of some of the equipment we had at the La Quinta Inn here in Charlottesville. The local homeless shelter had moved some of the homeless folks into the La Quinta Inn, and we set up equipment there. And that was easy because they had good broadband, good Wi-Fi, and it worked well. And UVA sent med students over to operate the equipment and see the patients, so that worked well. The one thing we did learn about, like nursing homes and the other facilities, COVID was equal opportunity. At nursing homes, it didn't matter if you were for profit, or in the jails. COVID was there, and the cases were going up. Next slide, please.
So I think it's important to note that by quickly delivering our GrubHub Telehealth capabilities to facilities, and then to be able to have strong clinical staff, pulmonologists, geriatricians, nursing staff, begin to triage patients, that quick team formation with a deep commitment to caring for these patients saved lives. We got patients to UVA, to ICU more quickly. We were able to keep the patients that could stay there. We were able to give the staff at the facilities competence. So it was working. And having a team that was ready to go made all the difference. And having a pulmonologist and geriatricians on that team made all the difference. To be able to consult with developmental pediatrics made all the difference. To have psychiatry at the fore. That quick team really was one of the major threads. And then to be able to get the technology out, as Mike described, to get a call in the afternoon, have the technology delivered, have all the instructions and the quick training, having tested it, knowing the passwords, all the kinds of things that we had to have ready, simple, easy, ready to go, pizza right out of the box, to test right then at the doorstep, such that by less than 24 hours later to be doing rounding on these patients, making decisions about their care, made all the difference. We were able to do this because we broke rules. You know, we were going to use whatever connectivity worked, and thank goodness for the rule changes that occurred on the national level, whether we could use Doximity or Doxime or Zoom, whatever we had to use to be able to connect, while all the time protecting what is important, number one, being able to see these patients and getting them into care as quickly as possibly, and providing the support to the staff, which we needed to be able to do because of their fear in this process. One of the big pieces that we saw early on was the need to finally change this paradigm. It's not that fixed endpoints they're extremely important, for instance, in a group home or in a prison environment, to have a fixed endpoint where people can get care. But the nature of the pandemic was such that we needed to get to the patient. And so to change a paradigm in the middle of a crisis is never easy. And so we recognized by needing to reach the patient, we also had to change the system, that you have to do both things at the same time with technologies that work. And Mike's going to discuss this some. The simpler the technology, the better. The more complex we got in that technology, the more we added on peripherals, the more difficult things became for us. Then finally, the thing that made it work was our good fortune to have nurse innovators, a particular nurse innovator who knew both technology, knew the clinical issues, but also could speak the language of the front end staff to know how those folks, how anxious they were, how if technology did not work quickly, how quickly it would be pushed to the side. So as Mike Ryan, an epidemiologist at WHO, said during this, you have to be fast and have no regrets. If you need to be right before you move, you will never win. And so we moved quickly. Next slide.
What didn't work well? There are lots of points of failure in telemedicine and telehealth, or can be potential points of failure. And as we're moving forward, we had the technologies, the stethoscopes, for example. We trying to pair them with iPads, you know, if there were Bluetooth stethoscopes, which we could do, no problem. But understand, on the iPads, we had several video chat programs. We were using WebEx and Zoom and Polycom and DoxyMe. And just for example, with a stethoscope, you may have to have another software program on the iPad in order for the stethoscope to work, because it wouldn't communicate down the channels, the audio channels of the video programs. So you can imagine the workflow where you're looking at video chat and you want to go to the stethoscope, you have to minimize the video chat, you bring up the stethoscope and you can't hear the video chat or it bleeds over. And so those are some of the things that we're thinking. And so like in the prisons, for example, a couple of those sites went to 2 iPads for video, one for or 2 iPads for the telemed encounter, one for the stethoscope, one for the video chat. And that works well on that end, sort of well. You're still kind of klutzy moving iPads around, but the provider side, it was very klutzy, you know, trying to move around. So that's just one. And we had, and with other stethoscopes, they had to communicate over, an example was connecting to the broadband at not only nursing home, but inside the prisons, very secure. One technology we're using only worked at 2.4 gigahertz. Is what, if you know anything about your home networks, you may have 2 broadband networks in your home, a 2.4 gigahertz and a 5 gigahertz. And the generation of technology we were using only worked on 2.4. When this first nursing home we found this, all they had was 5. And so we're kind of moving through learning, testing. We had tested in a controlled environment, it worked just fine. And we move out and it didn't work, or didn't work well. we didn't, when we were going to cellular, we didn't have too many problems with firewalls. But in some areas we did have trouble with firewalls, like the prisons and some of the nursing homes, and we'd have to work with IT staff behind the scenes to get the technologies to not only on the network, but to move through the firewalls. Broadband, I mentioned cellular iPads. So we're using consumer cellular iPads at a few sites. Testing the prisons and testing the nursing homes. And, you know, we all know about dead zones, and we weren't always in many of the prisons are in rural areas, so you're not getting good cell signal, even in the parking lot. But when we did, it didn't work well. So we were able to work with AT&T, and Verizon has the same sort of deal, and some of the other. We were able to get on their FirstNet service, which works, which they have for EMS and police and, you know, emergency folks. Prioritizes the traffic, so we're able to prioritize the telehealth traffic, which that helped a lot. But still, like in the prisons, you're behind concrete and steel. So we're trying to boost those signals in the prisons because, like I said, there's no Wi-Fi basically beyond administration, and there's no cell signals back in the cell. So as we're trying to boot, we tried several boosters. Some worked better, but we still couldn't get an adequate signal to do telehealth. We found a company, there's several of them out there, but we found a company that does an amazing job with boosting cell signals and can kind of work with several carriers at once and kind of bond the two carriers together, or three carriers, you know, pick the best signal, and just, you know, it's kind of seamless, you don't know. So, and it also sets up a wireless footprint for your devices, so you could, you know, you could do your 2.4 gigahertz or 5 gigahertz with your iPads or your stethoscopes or whatever you were using. That worked well. We tested at a number of places. This one prison we went to, we could hardly get a cell signal in the parking lot. But we took it back in the population. We're in a common area in the mental health ward of the prison. And we got a cell signal. I wasn't optimistic that it was going to work with this device all the way back into the cell area, prison cell area, not the cellular thing. But we tested it. We went through the steel door at the corridor to the pod, walked all the way back to the very end cells, prison cells, inside the cell with the steel door closed, only through the opening in the food tray opening of the prison door. We still had a beautiful signal, and that worked very well. We thought, oh, you know, now we have it. We've got a solution. This is going to be awesome. And you move down, you'll see security on the list. And you may be thinking HIPAA security, which HIPAA security is quite important, is very important to prisons. But the security we were meeting in the prisons was not necessarily, well, it was HIPAA, but we were meeting security because everything you bring into a prison is potentially contraband. An iPad could be potentially used as a weapon. The device we used to boost the cell signal had not been vetted by the State Department of Corrections. We had permission to go in and test all these devices, but when it came to finding what worked, we had a hurdle, we had a mountain. So we're kind of back to square one. And then with like training, you know, we have multiple shifts, and in the prisons especially, they may be moving healthcare staff from one prison to another and multiple shifts. So it became a challenge to train. And while we collected a lot of data, we could have done a much better job. And next slide, please.
So there are quite a number of lessons learned through this, and for today. We hope these things have value for you guys out there, knowing that we are at a moment where we're getting ready to end the public health emergency, and we're incredible, by the way, webinar last week, and I urge everyone to go look at it, about what the end of the public health emergency means to telehealth. It's very important to know, but that as we're facing that, there's some clear lessons learned that I think we need to apply to telehealth going forward in our planning, because it is extraordinary from GrubHub Telehealth that we actually could do a high definition telehealth encounter through the food slot of a steel door in the back of a mental health ward in a prison, such that we could provide care to a person that hadn't gotten care during this crisis. We can do these things, we can reach these patients, but only if we're prepared and we take these lessons and use them. That first, again, is use simple technologies. We need to continue to work hard for technologies that are interoperable and that are simple to use. Use those networks, those emergency networks, cellular networks that Mike described. Telehealth programs, clinical programs can use those. It allowed us to find ways to reach places that we couldn't otherwise reach. Thinking through the nursing role in particular, and as a communication bridge for this work, because that then leads into partnerships in the community. I cannot emphasize enough how important the fire marshal in our community was to our success in all these facilities, by knowing the first responders, by knowing the maps of these facilities, by having the contacts, by knowing the regs. We were able to design our plans based on guidance from the fire marshal. And then what we put together with GrubHub Telehealth, programs need to think through how they do that, how they deliver technology in these extraordinary moments. FedEx ain't the solution. We had to get ourselves there with technology that was ready to go. So ask yourself, do you have a plan for the next pandemic? We've done a great job. Mike and I share with Mike the fact that we've both had our first telehealth encounters for our own lives after the COVID got after here. We've been able to see our physicians that way. So we've come a long way for me as a patient of a health system. But do we have a plan for nursing facilities? Do we have good, solid plans for regional jails, prisons? I know great group homes do not. And so knowing the policy, knowing how we have to prepare for the future is important. Simplifying contracts and contract process is very important. And then in that context, which we learned and relearned in GrubHub Telehealth, to test, train. You have to keep doing it. There's so many staff that turn over in these environments such that you have to prepare both people and systems. 93% of the people who died during the pandemic by February of 2022 were over the age of 50 and had comorbidities. They were people with disabilities of all kinds, the most vulnerable people with complex medical conditions in these settings, and they accounted for the highest proportion of COVID-19 related deaths. So it's something we need to do. Next slide, please. So what do? We continue to develop the role of the clinical nurse innovator. I think that's a role we really need to talk about. We need to find solutions to some significant technology challenges. None of this is to say that places didn't do it extremely well. And at moments, we did it extremely well. Those article citations you saw up under GrubHub Telehealth, those are our story about the way we saved lives by using these capabilities. But there are technology challenges like stethoscopes and other peripherals we need to keep working on. There are great things on the market, but they're also complex when you take them out to these kinds of settings. So programs ahead of time, designed and present, having boots on the ground capability is important. Advocating for policy change. The work that we have all done through the telehealth resource centers to increase awareness of telehealth. I would point you to our Matrix a web page where there's an extraordinary variety of data on lessons learned from COVID, best practice examples, things to think about as we not only build telehealth into the electronic medical record and take care of our existing patients in our facilities, but also to think about how we reach those who are our true VIPs, so that we have a systematic response to telehealth in congregate settings. And so we can party like it's 2020 rather than 1999. The flag's coming down. The national emergency is ending, but we are getting and must be prepared for another emergency because they are likely. Last slide, please. So everybody can see that, but we can't.
We can't.
Blocked by our pretty picture
Yeah,
of
so
the two crudgery old telehealth workers here. It's just the charge that we all have now is to see whether this can really serve as a wake-up call for us. We are now in the start of the third year. We should have the care of individuals in congregate settings as a major goal to see how we can measurably improve that care. Yeah. Questions?
Awesome. We've got a couple of questions in the chat. One is, does anyone in your organization speak the jargon of the inmates?
That was, I can't tell you how important that is. The person was not in our organization, but the person was the nurse innovator within the correctional facilities and had done correctional healthcare for many, many years. And so Mike and I were not thinking, oh yeah, you can actually make a shiv out of a cart that you put an iPad on. She was able to understand what needed to get approved and how we needed to move it into those facilities. So those partnerships cannot be underestimated.
And we were also working with the wardens and the lead security officers and all the medical staff at each and every prison.
All right, next question is the only HIPAA security available in the cloud encryption?
Repeat that question, Kathy, if you don't mind.
Yeah, the question was, is the only HIPAA security available in the cloud encryption? So I guess the question is encryption the only way the only mechanism for ensuring the HIPAA security for cloud-based services?
You can create VPNs and permanent virtual circuits and things in the old school way of configuring circuits, but with today's technology, endpoint to endpoint encryption through the cloud is a best practice.
We did have a nightmare because of security of just shifting passwords. I mean, it made our head hurt every day. And we all have that in our personal lives. And if we're going to have to move quickly in crisis environments, while at the same time protecting confidentiality and safety and encryption, especially in places like prisons. We're going to need new technology. I see stuff out there with people working with passkeys and other things. I think those things are going to become vital for us as we prepare going down the road. We can't lose two days time because we can't figure out how to work with password changes. And we would get password changes and downloads from the companies right in the middle of providing care.
For some of the apps, you had to have an account set up through the servers of the company or through UVA. One thing that was important to note that I did not say, and this happened in one of our first nursing homes, we were told that the only place we're going to do encounters is going to be in the medical clinic or in the medical rooms, right outside the clinic. They are the only places we're going to do it. We had tested, it worked well. We explained to the physicians, everyone was on board. I think this was before we had a nurse innovator, by the way. And, but the very next day we get an email or call that, hey, the technology didn't work. And so it wasn't only the prisons, they were, if you're going into the individual residence of assisted living, or they're responsible, and in some of the nursing homes, they're responsible for their own, internet connection. So, which would also be kind of a nightmare you'd have to set it up on each individual, residence network. So that then hence cellular. And we had similar problems at several of the nursing homes where you may have great cell coverage, and even without the boosters that we were talking about, we'd have great cell coverage, and invariably they'd want to use it in an area that didn't have great cell coverage. And so it's in our mindset, it's always been, I learned this from Colonel Eugene Sullivan, it's easier to move technology than it is to move people. And this was certainly true during COVID. And so we were scrambling just to do whatever we could to make it work.
Another question, how can technologies be leveraged to prevent infections in hospitals and institutions?
I think that's the place where we were most prepared.
Yes.
Because fortunately at UVA, we were an Ebola rule out hospital, and Ebola got us prepared for means to be able to use video conferencing capabilities in a room, at a nursing station, and from a physician or a caregiver at home, for other professions, social work, nutrition, other people who did not need to go through a door, but who could talk to the patient in an environment, mind you, where that could be turned off so that the patient could have privacy. But that there is a way to actually measure that. You can measure the number of door clicks to a room. And if you put telehealth capability into rooms in hospitals where you can measure that door click, and you can reduce that door click by having basic things, basic questions answered, concerns, family connections, etc., through telehealth, you can reduce infection. And in the moments of airborne infection, when we're going to face things like the avian flu and H1N1 in hospitals, our genuine hope and desire is this is going to be the standard for entire hospitals.
Absolutely. So another question, what regulatory limits do you still frequently encounter at this point? Are nurse and physician licensing a difficulty that you frequently encounter, as it is state by state in a majority of states? Does compact licensure help?
Amen, amen, and amen. Compact licensure would help. I mean, we have staffing issues in our system. I mean, I look at the health system as a whole, we have staffing issues. And then you look at a small rural nursing home, or the surround of that community, or the need for a pulmonologist. Compacts help address the need for specialty practice. It also bolsters the workforce, and it aids us in a crisis to be able to rely on that. So yes, that there is no question. The biggest problem we faced in the most immediate ways is that telehealth licensure, because of Stark regulations, is still so damn hard. And we talked about it in the last webinar. You know, the red line goes back to the other lawyer, and then to a clinician, and then to an administrator. We have got to develop a simpler template contract that we employ nationwide, especially in the light of emergencies and a pandemic, so that is not a roadblock for the immediate use of telehealth.
Yeah, the whole contracting issue, I think nobody has really addressed at all nationally, and that has been, one of the major roadblocks is how do you quickly create contracts between entities that don't originally have contracts, and do that in the midst of an emergency where lawyers are, trying to dot I's and cross T's and change, simple words. It is a crazy kind of roadblock that shouldn't be there.
And so we ended up, Kathy, breaking the rules. We ended up using language like, well, now that patient is a patient of Dr. Smith from the health system, and we were treating that as the sacred relationship that it is, and not the telehealth as a contractual service of that nursing home, so that we were just ducking and dodging Stark considerations, because it was life and death. So we've got to, in this interim period, which could end at any time, time spent on contracting and simplification is worthwhile.
And for those of you who don't know the Stark laws, there was definitely during the pandemic a relaxation of that, but as the public health emergency ends, that is going to come back. And Stark laws were put into place so to prevent large hospitals and health systems from what they call inducing referrals. And by inducing referrals, they mean, if I give you a bunch of great supplies, for telehealth, so if I give you cards and I give you all this, it'll be the appearance that since I received all these freebies, then I am kind of bound or obligated to send my patients to you via the telehealth visits, and then to you in-person visits. And so that's what the federal government tried to stop happening. So it required you to have these contracts in place, and required, the hospitals, health systems, even vendors to not be able to give away products. So you'd have to have contracts where the entity that you're sending equipment to, let's say a nursing home or whatever, they're actually having to pay for anything that they receive, unless, and the only exception workaround was like if you applied for a federal grant and got that grant for that entity, then you can kind of purchase the equipment off the grant and give it to that nursing home or prison. And so that was definitely a challenge, and will be a challenge after the public health emergency ends.
And I would just argue there's a lot of difference between giving a small hospital an MRI to induce referrals for neurosurgical care than giving somebody an iPad during the gulf of pandemic.
Yeah, but the law doesn't recognize those differences. And I think that is one thing that a lot of policymakers are at least trying to address, but has not quite gotten there yet. We have a few comments in the chat. One is, have any of you listened to Tupac? And did Tupac speak the inmates jargon in his rap music?
Yep.
Yeah.
All right, I think those are all the questions we have. And one comment was just awesome applications of these revolutionary products and technologies. Right, Aria?
Thank you, Kathy, and thank you, David and Mike, for your presentation today. I'm just going to bring up our closing slides. There we go. Just a reminder that our next webinar will be held on Thursday, March 16th. That will be on leveraging telemedicine to eliminate outcome disparities for rural-born newborns, and that will be hosted by the Northeast Telehealth Resource Center. Registration information is available on the NCTRC events page. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to the Mid-Atlantic Telehealth Resource Center for hosting today's webinar. Have a great day, everyone.
If,
Thank you.